Good evening, everyone. My name is Melanie Ionase, and I am the Physician Relations Specialist here at Rothman. Tonight's webinar is with Dr. Saxena, total joint surgeon here at Rothman. His office locations are at Hamilton, Pennington, and Princeton. The topic that he'll be covering this evening is hip and knee arthritis, understanding your options. Dr. Saxena will give us an insightful discussion on managing arthritis in the hip and knee joints. He brings his wealth of expertise to this session, offering comprehensive insights into the diverse range of treatment options available. From conservative therapies to advanced surgical interventions, this lecture aims to equip attendees with a nuanced understanding of the causes, symptoms, and tailored strategies for effectively addressing hip and knee arthritis. We hope you gain valuable knowledge from a seasoned expert and empower yourself with informed choices for optimal joint health. So just a few quick notes at the bottom of your screen. You're going to see a Q&A icon where you could enter any questions you have throughout the presentation. We will have time at the end to answer as many as we possibly can get to. Also in the chat box, I will share Rothman's phone number, and if you'd like to make an appointment as well as my information for any assistance you may need in the future. So without further delay, I will pass this off to Dr. Saxena. Dr. Saxena, welcome, and thank you so much for your time this evening.
Hi, Mel. Thanks so much for setting this up, and thanks to all the attendees for taking time. And I hope everyone will find this valuable and gain maybe even just a tip or two on kind of dealing with yours or a loved one's hip or knee pain. Also, want to do a big shout out to Kristen Bellamy, who set this up. She is one of our marketing stars here at Rothman. And just a big thank you to Kristen for all she's done. So we're going to talk about hip and knee arthritis. I have some slides here. I'd love to see your questions as well. So let's get going. Let's see if this will advance. There we go. So we're going to start with hip arthritis. Basically, how does the hip work? It's a ball and socket joint. So if you can see my mouse here, this is your femur or your thigh bone, and there's a ball on top of that called the femoral head. And there's a socket, which that ball articulates with, called the pelvis or acetabulum. And in that socket, the bones are covered with cartilage, which is a soft surface that allows very smooth motion when cartilage rubs on cartilage. And so what happens in arthritis is people lose cartilage, and that causes bone to rub on bone, and the motion then becomes stiffer, it becomes less smooth, and that can cause pain. So we'll talk a little bit about hip arthritis and what the symptoms are, and then what the treatment options are. So 70 million people in the United States have some form of arthritis, and osteoarthritis is one of the most common ones. It's a wear and tear that deteriorates the cushion or the cartilage in your joints, and it's a degenerative condition that won't get better and will likely get worse over time. You can develop arthritis because you have abnormal anatomy. Maybe you had an abnormal hip when you were born. Maybe you had a fracture and now you have hardware in there. Abnormal biology. So if you have abnormal blood flow to the femoral head, a condition known as avascular necrosis. That's what Bo Jackson had, the famous dual sport star. That can lead to arthritis or a degenerative condition of the hip. Overuse is one, and then genetics. You know, a lot of our patients say, "Oh, I have hip arthritis. My brother had a hip replacement, 3 or 4 years ago, or my mom and dad had both of their hips or knees replaced." So we see that a lot. There's a huge genetic component to this that we probably don't fully understand yet. So again, what causes pain in arthritis? Whether it's your finger, whether it's your hip, whether it's your knee. The healthy joint where two bones meet is going to be covered in cartilage, which acts as a cushion so the joint functions without pain. In a diseased joint, the wear and tear deteriorates that natural cushion, and that leads to bone-on-bone contact, soreness, and swelling. So I liken it to a door hinge. This is a normal functioning joint in a brand new door. Healthy, cartilage, well lubricated, full motion, pain-free. Now, over time, normal function, something we take for granted, when you can walk, get in and out of a car without any issue or thought, exercise, sleep, and enjoy life without pain. Over time, that new door hinge becomes an osteoarthritic joint. So this is rusty, it creaks, it cracks, it's damaged cartilage, there's no lubricating mechanism there, there's loss of motion, it's stiffer, and there's pain associated with it. So an osteoarthritic joint is almost like a rusty door hinge. So when we ask people with hip pain, how much pain do they have, or how much is their hip arthritis affecting them? There's a couple of basic questions we can also often ask. Number one, do you limp? Like maybe after a certain amount of distance, you start limping. Number two, difficulty performing like simple daily tasks, walking, housework, and the big one is tying shoes. Believe it or not, sometimes you just need a physical exam and a questionnaire to diagnose arthritis, not a fancy MRI or anything. The biggest complaint people will have is they have trouble getting on socks and shoes because the arthritic joint gets stiffer and they don't have the range of motion to get their foot up to do that. We ask how their activities and lifestyle are limited. Sometimes with hip arthritis, one leg can feel shorter. Sometimes they can have balance problems. Most people with hip arthritis are going to report pain in the groin, the thigh, or the butt. So a lot of people kind of look to the side of their body and point to that as their hip, and that's not really where hip pain is. It's really going to be in the thigh, the groin, or the butt. Sometimes pain can actually even radiate down to the knee. So how can we treat arthritic pain associated with hip arthritis? So exercise and physical therapy are key. When you have arthritis, you want to keep moving your joint. So maybe you modify that. Maybe if you have hip arthritis, you stop running and maybe you start using an exercise bike or an elliptical so there's less pounding on the joint. Water therapy like heat or ice or cold packs can help. Medications like anti-inflammatories, Motrin, Tylenol, or even a steroid pack can help. And then steroid injections can also help. When these things fail, when the non-operative treatment methods fail, a hip replacement is a very good option. Basically, it's a surgery that can relieve pain and improve mobility by replacing the damaged surfaces. Very common. This number is from 2009, but I bet you the number is closer to 1 million hip replacements a year in our country. So what's a hip replacement? Here's a picture of that first picture we started with, the first cartoon we started with of a femur or a hip joint. So what we do in a hip replacement is we cut the bone right here at what's called the femoral neck, and we throw the femoral head away. So in surgery, we're sort of looking at this bone that's kind of not connected to the rest of your body. And what we do is we put a metal shell in the pelvis or acetabulum, a metal stem inside the femur. So you can't feel these, they're inside the bone. And then we put a ball and a liner to sort of articulate that to really kind of recreate your normal anatomy. And that's sort of the goal of the surgery, is to recreate your anatomy. So here's a preoperative x-ray. Okay, this is an arthritic hip. Okay, the bones are touching right there. There's a bunch of cysts in the joint, in the hip bone, or in the femur bone, excuse me, and a very hardening of the bone here called sclerosis. Now here's a replaced hip. It looks pretty similar, except this white is the real solid white is the implant. So here's the acetabular component, here's the femoral component, and here's the ball articulating there. So one of the ways I like to do a hip replacement is through what's called an anterior approach. So classically, you'll see the hip replacements, the incisions are going to be kind of on the side of your hip or back towards your butt. And in an anterior approach, I can work between some muscles and tissues without detaching them from the hip or thigh bones. And the hope is that lets people function a little better, a little quicker. So in a traditional surgery, most patients are lying on their side. When I do an anterior approach, I use this torture device here. Don't worry, it doesn't hurt. You're under anesthesia. But what I can do is I can not only get the access to the hip joint, but I can also expose the bones to put the implants in using these leg spars. I can use an x-ray machine to check component placement and leg length during the procedure as well. So I like to do it this way. Hip replacement is a very, very successful surgery. They dubbed it the operation of the century for last century because it truly changes people's quality of life. Even people who have hip fractures get hip replacements sometimes, and it can get them recovered much faster. Most people who have hip replacements, overwhelmingly 96, 95, 98%, depending on the study you read, are very happy and satisfied with their hip replacements. So in summary, for hips, the leading cause of hip pain is osteoarthritis, and it's a degenerative condition that won't get better and may get worse over time. Early diagnosis and treatment are important because those non-operative things I mentioned can absolutely help your pain. Hip replacement's a great surgery when you want to relieve pain and improve mobility. And you want to do the hip replacement when your pain is so severe, when your quality of life is adversely affected, that you just can't deal with it anymore. And as far as implants, there's a lot of companies out there that make good implants that work. So your surgeon can help choose the right implant, or really it's usually going to be the implant they just happen to use the most. Moving on to the knee is a little different because it's a different joint. The hip is kind of more like a ball and socket, and the knee is a little more like a hinge. So here's your femur or your thigh bone, and here's your tibia or your shin bone. And here's your kneecap or your patella. And in between these bones, we have cartilage. And the cartilage, again, allows the bones to move through the range of motion and allows the joint to move smoothly and without pain. So Again, same thing. Arthritis is the most common cause of knee pain, wear and tear that degenerates that cushion or the cartilage in your joints. So here's an x-ray on this over here of a normal knee with black space between the bones. That's good. Femur, tibia right here. The kneecap's here, okay? And then here's an arthritic joint. You can see the bones are touching right here, and there's even like little cysts in the bone. Here's a good cartoon. So basically, here's the femur, here's the tibia, there's the ACL, there's a meniscus, and you can see this cartilage should look like this, but in spots, it's broken down, and now you have exposed bone. And that's what we see a lot of times when we go in surgery and we're looking at an arthritic femur or tibia, we see just patches of loss of cartilage, and that can cause a lot of pain and swelling and dysfunction. So we ask patients who have knee arthritis, okay, so how often does your knee hurt? Does it hurt every day, once a week? A lot of patients with knee arthritis will have trouble sleeping, walking. How far can they walk without pain? The non-operative treatments, are they not working? Are they limiting participation in activities, whether it's work or family functions? And then the big one, has knee pain cause inactivity, which actually causes you to gain weight? That's a problem because that's going to make the problem worse. So how can knee pain be treated from arthritis? Same kind of principles, water therapy like soaking or ice or heat, exercise and physical therapy, very good. I tell all my knee arthritis patients, best exercise is a recumbent exercise bike. You're sitting up and you're pedaling, and it takes a lot of the forces from the weight of the rest of your body off of the joint. That's really helpful. Medications, anti-inflammatories and steroids can help. Injections, you can get injected steroids as well. And then you've probably heard of the rooster comb or chicken egg or Orthovisc or Monovisc or Synvisc. There's all different formulations, but these hyaluronic acid injections can also alleviate some of the pain and act as a lubricant for the joint. So in knee replacement, when those non-operative treatments have failed and the quality of life is adversely affected and something a patient just doesn't want to deal with anymore, this is a great surgical option. I think this figure is old. We're probably approaching 1 million a year in our country at this point, and it's a great surgery that can help relieve pain and restore mobility. So here's what a knee replacement looks like. This is a model bone, we call a sawbone in orthopedics. This is your femur, this is your tibia. So a knee replacement really is probably a little bit of a misnomer. It should probably be called a knee resurfacing, because we just remove a thin portion of diseased bone and cartilage off of the end of the femur. This here is probably like 9 millimeters thick, this metal component. And same thing with the tibia. A thin portion of diseased bone and cartilage is removed, and you can put a metal piece on the tibia and then a piece of plastic in between. And now instead of bone rubbing on bone, you have metal rubbing on plastic. So here is an x-ray of what that looks like. Here's the metal femur on solid white, metal tibia solid white, and then the plastic doesn't show up on x-ray, so it looks black. So here's an example of a healthy knee with space, black space between the bones. And again, here's another example of a knee replacement. So in summary, the leading cause of knee pain is arthritis as we age, a degenerative condition that'll get worse over time and might get better. And early diagnosis and treatment are really important because you can last a long time with non-surgical treatment with pain relief and being able to function. So it's really important to utilize that non-surgical treatment. Patients are highly satisfied with this procedure, though probably not as good of a procedure as hip replacement. Knee replacements are typically a little harder to recover from, so they're a little tougher. And same thing, there's a lot of companies that make good implants. Usually you're just going to go with what your surgeon feels most comfortable for you. So what can you expect? Because this is like a big question. People seem to be often less concerned with what we're actually going to do in surgery and more what they can expect after the surgery. So hospital stay, if you're talking about your grandmom's or your mom's hip replacement 15 years ago, they might stay in a hospital 3 or 4 days. They might go to a rehab for 3 or 4 weeks. Now, people are actually leaving the same day from the hospital. At Rothman, probably about 40 to 50% of patients go home the same day. So it's nice, actually. You don't have to sleep in a crappy hospital mattress. You don't have somebody waking you up at 3 in the morning to check your blood pressure when you're fast asleep. You go home and you stay in your own bed and you just relax. And that's a great way to recover for a lot of patients. What we focused on more than anything in the last decade or so is recovery for patients. Not so much the implants are probably pretty close to the same as they were. It's the recovery. So how can we make you recover faster? Well, we found in orthopedics that and really across all disciplines in orthopedics, not just hip and knee replacement, if we control pain better and we control nausea better, patients can do their therapy sooner and do a better job and get mobile faster. And so that's really a big component to recovery at this point is all the things we can do to control pain, which we'll talk about in a little bit. Returning to work, a very important question. Kind of depends on what you do. If you have a really sedentary job and you can work remotely from home, you could probably go back to work a couple days after surgery. If you are a construction worker or a laborer and you need to be out there and using heavy equipment and on a construction site, you might need 3 months out of work. So everybody's a little different in their situation. So, what is outpatient joint replacement? It's what it sounds like. It's having surgery and going home the same day. And it's more common now because really the pain control and the nausea control have gotten better. So those were the things that would often limit people from doing the rehab to get moving and get out of the hospital. And, am I a candidate? Everybody wants to know. And it really depends on your medical comorbidities. So how sick are you? How many medical problems do you have? And that's kind of an individual thing for each patient. And we operate at a lot of different facilities at Rothman, but all of them have a preoperative risk stratification or optimization protocol. So we want to make sure our patients are as safe as possible and in the best shape possible for their surgery, so they're set up for a good outcome. So when we talk about outpatient joint replacement, safety is really key. So again, it's all about patient selection and optimization. So we want low-risk patients. Our anesthesiologists use a term called American Society of Anesthesia Classification. We want the lower end of the patients. We want your hemoglobin A1C to be less than 8. So that means your diabetes should be well controlled if you have that. Typically, your BMI, we want it to be less than 40 or at least very close to 40. Ideally, smokers wouldn't smoke. Those patients tend to have more pulmonary complications. So we feel better having those people go home the day of surgery if they're not smoking. Anemia is really important. Your blood counts. We want to make sure everybody has an appropriate or normal blood count before surgery. Infection prevention. You're going to do this whether you have surgery as an outpatient or an inpatient, but we have you wipe with antibacterial wipes, so really all over your body. We clean your nose because sometimes your nose can harbor bacteria. And then we do the standard things, as far as room and instrument cleaning that you would do at a hospital or a surgery center. So it's really important for patients to have the right expectations. Patients have to be prepared. You have to be mentally prepared that you're going to go home, that you may deal with some discomfort at home. It's helpful to have a caregiver or a coach. Ideally, you wouldn't have questions post-operatively. So a lot of our doctors have preoperative packets that we give to patients. Really important that patients read through those packets and understand everything in them. The big thing I think is patients have a fear of the unknown when it comes to surgery. They don't know what it is. They don't know what's going to happen. Am I going to wake up? These are all the questions. And so, what we try to do is educate, and we tell people, how they're going to manage their pain. Are you going to need to depend on others? That's a concern for a lot of people. Driving, when can you drive? Usually sometime after 2 weeks, it's probably reasonable to try that. Going back to work, again, very specific to an individual's position. And when will I feel normal is a big question. And that's a tough one because even if a surgery is totally successful, a lot of times patients don't feel normal for 2, 4, 6 months, even a year after the surgery. So it's definitely a process to have a hip or a knee replacement. So not something that you just kind of get done and are, quote unquote, good the next day or the next week. So in outpatient joint replacement, we talk about what's called multimodal analgesia. And what that means is that's about taking care of pain or treating pain through different pathways in the body. So we give pain medication before surgery, during surgery, and after surgery. And so that's really helpful to try to keep that pain controlled so patients can work with therapy and kind of walk, really we have people walking out of our surgery center sometimes 2-3 hours after a surgery. And so another key with joint replacement in general, whether it's outpatient or not, is oftentimes working with PT, especially for knees. A lot of times hip patients don't need this, but with knee replacement, a lot of times physical therapy is really helpful. Sometimes going to therapy ahead of time is really helpful. So I encourage people to do at least one session before surgery. What about medical equipment? Do you need a walker or a commode or a shower chair? Always good to plan ahead. Most of our facilities will help people get these on the day of surgery, but if you can get it beforehand, it's just one less thing you got to worry about. We usually have physical therapy come see every patient in the recovery room, or if they're staying in a hospital on a floor on the inpatient floor, the day of surgery, and then steps. Steps are a big factor. If you have steps at home, a lot of people are concerned about going up and down steps after surgery. Believe it or not, that's actually part of your therapy. We want you going up and down steps. And we have steps that you can practice on in our facilities, so you feel safe before surgery. Again, that's a great thing. You can kind of understand the mechanics of before your procedure. And so people always ask in these talks, how can I prevent a joint replacement? And then there's really two things you can do. You can stay active with an exercise program, and you can control your weight. The number one thing we know is that the heavier you are, the more likely you're going to develop arthritis in your hip, knee, or ankle. There's some studies, longitudinal studies performed in countries where they have nationalized healthcare systems, and they found people who are even just 10, 15 pounds overweight in their 20s are like 3 times more likely to get a hip or knee replacement in their 50s or 60s. So there's a direct correlation between weight and arthritic joints. That's pretty much what I had for you today as far as wanting people to understand, a little more about hip and knee arthritis and treatment options. Mel, I'd love to see, what questions people have. So let me see, I'll pull up the Q&A here and I can go through.
Okay. So let's do that for you, but go ahead. That sounds great.
Yeah, so this is a kind of a long one. I'm going to come back to this long one for Christine, okay? So a patient had a question. They're seeing one of my partners, but didn't mention this version of surgery. So they're nervous about making the right decision. And I will tell you that, every type of there's 4 main approaches to hip replacements, and they all work very well. I just happen to do 2 of them, and they both work really well. So as long as you're comfortable with your surgeon, I would trust, whatever they're doing. And to be perfectly honest with you, I usually don't even mention the approach to my patients. And sometimes before surgery, they'll say, "Hey doc, what surgery am I getting?" I'm like, "You're getting a hip replacement," and they don't even know. And to be honest, the approach really doesn't matter. So you don't need to be nervous. What's appropriate blood count needed before surgery? Well, it's different for men and women, but usually you want the hemoglobin above 12. And what that indicates is that usually you're going to lose some blood with surgery, but usually it's not enough to need a blood transfusion. But if you're above 12, it's pretty reliable that you won't have a complication due to blood loss after surgery that would require a blood transfusion or anything like that. So usually above 12 is a safe hemoglobin. Next question was, if you have arthritis in both knees, is it recommended to have them replaced at the same time or separately? Every surgeon probably has a different answer on this. I'm really about safety, as you saw in some of my slides, a lot of safety slides. And so, when you're doing 2 joints, there is a certain amount of blood loss that you will have, and it's not all in surgery. Your body tends to sort of quote unquote leak blood for 2 or 3 days after surgery. And so your blood counts can keep going down. So I just think if you do 2 joints at the same time, there's a higher risk that you may need a blood transfusion or have some type of complication with that. So in a healthy patient, with really minimal, lung or cardiac issues, it's probably reasonable to do both at the same time. But I rarely offer that anymore. I just think it's really hard to have both knees being rehabbed and being operated on at the same time. Can I kneel after knee replacement? Common question. Yes, you can. Most people don't like to kneel right after the surgery because the bottom part of that incision is right on the tibia, like the shin bone. There's not a lot of fat or tissue there to pad it, so that area can get irritated. I usually tell people to wait about 4 months, and then I'll give them like a desensitization program to really help with kneeling. A lot of times, whether it's prayer, whether it's gardening, or whether it's playing with grandchildren or pets, people do want to kneel, and you definitely can after a knee replacement. If I have surgery done at Rothman, which is an hour away, do I need to do PT there? No. PT, we offer it at all of our offices, but really you want to do it at a place that's convenient to you in your home because you got to go. And if you're going to PT, you got to go like 3 times a week. So really, ideally, your ideal physical therapy place would be, within, 20, 30 minutes of your home. Is there a max age for having a knee replaced? No, there is not. My oldest knee replacement patient was 94 years old, and he did wonderfully. I will tell you, though, as we get older, 85, 87, 91, there's a higher rate of complications from surgery, even if everything goes perfect. So, it's not ideal as people are in their late 80s or early 90s, but it certainly can be done. What's the current thinking of surgical treatment of a torn meniscus when non-surgical modalities have failed? Well, if you just have a torn meniscus and you don't have arthritis, a knee arthroscopy, which I didn't talk about today, is a great procedure. And we do a lot of those at the Rothman Institute, and that can be a great procedure to kind of alleviate your pain. So it's important you kind of talk to your doctor, use all the non-operative treatment options, because not every meniscus tear needs surgery. Do patients need a blood transfusion? Usually no. For a regular standard total hip or total knee, the blood transfusion rate is very low. We're talking like less than 1% of them, maybe less than 3% of the time. So pretty commonly you do not need a blood transfusion. And in the past, maybe 10, 15 years ago, people used to like auto donate blood and then they'd have it transfused back. We actually just stopped doing that, and that actually decreased the rate of transfusion. So just hang on to your blood yourself, and most likely you won't need a blood transfusion. Would you replace two knees within 2 days of each other? Again, kind of goes back to, having a good leg to stand on. So I tell people to wait at least a couple months between knee replacements. And then also the medical comorbidities, 2 days between surgeries probably isn't enough to kind of decrease that. Are there dietary restrictions post-op? Not really, but ideally, for surgical healing, you're gonna want a high protein diet with leafy greens. You're gonna wanna make sure if you have diabetes, your blood sugars are well controlled. These are all things that promote healing. So those are the kind of things you wanna think about. Would you do an epidural for anesthesia? So an epidural injection is a needle in the back, and a lot of people know what that is from pregnancy. And basically what that'll do is that'll make you numb below the waist. And that can be a great way to do a hip or knee replacement. I would say probably the overwhelming majority of our hip or knee replacements are done via spinal or epidural anesthesia. And it's a bit safer, and it's a great way to do the surgery. So if you don't want general anesthesia, you don't want a tube put down your throat, it's a great way to do it. Do you recommend cortisone injections? And how frequently or how many years? Yeah, I mean, cortisone injections are a non-operative treatment option for hip or knee arthritis. You can really do an unlimited amount. I recommend they always be spaced out within 3 months from one another. But what we find is that the more of them you get, the less effective they are. So it's not too common that people will spend, 5, 10 years getting cortisone injections. But if they work and they provide, 3, 6, 8, 9 months worth of relief, it's reasonable to keep doing them. Do you get IV antibiotics during surgery? Yes, pretty much with any surgery where your skin is cut, you will likely get an IV antibiotic right before the surgery. So a lot of people don't necessarily realize that when they have surgery, but yes, you would. Right time to do a hip replacement? Well, it's really, comes back to you. So as a doctor, I'll examine you, I'll talk to you and find out, what's bothering you. And I'll, look at your medical history, and I'll look at your x-rays, because that's all you need. You don't need much more. And then I'll say, hey, look, you're a candidate for this. But when to do a hip or a knee replacement is really the patient's decision. And it's really, again, it's just when their quality of life is so adversely affected that they just can't deal with it anymore. Would knee arthritis cause leg pain and not just knee pain? Absolutely would. As hip arthritis can often radiate down to the knee arthritis can radiate into the shin and whatnot. So yes, it absolutely can. Pain can move. Would like to hear about preventive action for knee arthritis. Absolutely. So that last slide is the key. It's staying active and it's weight control. As we get older, balance and stretching exercises are very helpful to prevent falls and to kind of maintain balance, because that does tend to diminish as you get older. So I always say, if you're going to do an exercise program, it really needs to be 3-pronged. So you need to have a cardio component, where your heart rate gets up. Okay. You need to have a strength training component where you're really kind of strengthening the muscles and keeping your core muscles strong. And then you need to have a balance and flexibility program. So really, that's kind of just for as you get older. I think everybody needs this. Sitting on the couch, being a couch potato, is not the way to stay healthy and to keep moving. How would you determine if a hip problem is related to arthritis or a tear in the labrum? The first step you're going to do, the labrum, by the way, is the shock absorber in the hip joint between the cartilage, similar to the meniscus in the knee. The first thing you're going to do is get an x-ray. If you have arthritis that's bad enough on x-ray, you don't need any further workup. It's just arthritis. But if the arthritis isn't so bad and there's some cartilage left, an MRI could determine if there's a labral tear and kind of take you down the path of what treatment options might work there. Do you recommend Euflexa injections, and how frequently? Euflexa is one of the brands of the viscosupplementation or the gel injections. These are FDA approved for knee arthritis only. And yes, we do tons of these for patients. They can work really well. They tend to work better in people who have mild arthritis, not so great in people who have severe arthritis. But if a round of viscosupplementation injections gets you 6 months or a year's worth of pain relief, that can be really helpful. And you can do that for a number of years. Knee surgeries are ligaments, tendons, muscles severed, cut, removed, sprained. Yes, to access the knee joint, you do have to get in there, and you do have to make some sort of cut in soft tissue. Usually, in a knee replacement, the ACL is removed. The PCL is often removed as well. The collateral ligaments, the MCL and the LCL, will remain in place, and the meniscus on both sides of the knee will be removed usually. Does there need to be bone on bone for knee replacement, or if injections aren't working and you have pain every day, could you do it? Yeah, I mean, it doesn't have to be bone on bone, but what we tend to find is the patients that benefit the most do have pretty significant arthritis. So yeah, if somebody had like really mild arthritis and on x-ray and they weren't getting better, I'd probably do more of a workup. I'd probably, examine other parts of the body. I might get a knee MRI. So I wouldn't necessarily jump to a knee replacement in that patient. Great question. How long are implants expected to be functional? Are revisions used often? We have good data that shows hip and knee replacements will last 20 years, about 80 to 90% of the time. That doesn't mean they fail year 20 and day one, so they can last quite a long time. Revisions are performed. I'd say there's probably about a 1 or 2% revision rate every year. And so revision can be a very simple procedure where you're changing one part, or it can be a huge procedure because of an infection or a fracture. So it's a pretty wide array of things that can happen. We take care of all those at the Rothman Institute. Epidural for hip. Yeah, I apologize for anesthesia, whether you're getting an epidural or a spinal. We usually use an epidural spinal anesthetic for a hip or a knee replacement. So the anesthesia is pretty much the same for both. Do you recommend regenerative pain therapies? This is a pretty controversial question. There's some data out there that says platelet-rich plasma or PRP injections can be helpful for knee arthritis. And then there's some people out there that claim stem cells can be really helpful. But what no data shows is that these treatments, PRP, stem cells, etc., no data and no science shows that they regrow cartilage. So any of these injections are going to serve an anti-inflammatory purpose and a pain relief purpose, and that's it. Nothing is going to regrow cartilage at this point. Maybe one day we'll have something like that, but that would be the real, the key to non-operative surgery would be to regrowing cartilage, which none of the regenerative surgeries do that. So they call themselves regenerative, but they're not actually generating or regenerating anything, but they can be very good as far as anti-inflammatory. Question about they have a low hemoglobin, so how can that increase? Well, you'd want to have iron, so that's number one. An iron supplement can help increase your blood counts. And then you'd want to work with a hematologist. There's medications that can help too. Now, look, some patients, you just can't get it better. And then you go ahead with surgery, and there's a little bit of an increased risk there. But working with a hematologist or your primary care to increase those counts using supplements like iron or B12, and then also there's medications that can be used as well. How many times can you have cortisone injections before knee surgery? There's no real number. The one thing I will tell people is I try to delay surgery 3 months after a cortisone injection because there's a slightly higher risk of infection. But you could have as many as you want. But again, I would only want to do a cortisone injection for you if it worked. So if you only get 2 days worth of relief from a cortisone injection and you can't get another one for 3 months, I wouldn't really bother doing an injection for you at that point. Question about robotic knee replacement. Robotics are a great tool for surgeons. There's a lot of different variations of them out there. They can absolutely help surgeons put implants in desired positions desired positions. It works well. The studies haven't been great about the robotic or navigation techniques. They haven't shown the outcomes to be significantly better, but they're good techniques. And so then that comes back to, kind of just picking a surgeon you trust and then letting them do the surgery kind of the way they do it, because that's going to give you the best outcome. Someone's son had 3 surgeries, one at age 2, one at age 16, and one later on. He's only 24 years old, so that's a tough problem. So that's somebody who probably had abnormal anatomy as a kid. And, unfortunately, the hip has degenerated at a very young age. And so the short answer is yes, he can get a hip replacement, but, there are consequences to having a hip replacement at that age. So that's a long conversation to have. But it really comes back to quality of life. I think we have a guest visitor right here.
Hey.
There she is.
Hi.
Nana, can you go talk to mommy? Daddy's talking to some work friends. Thanks, honey. All right. So sorry about that, guys, but when the baby girl calls, we got to answer.
Agreed.
And so when you replace the knee, does that solve any meniscus problems? It does, because you cut out the meniscus, because the plastic part of the knee replacement kind of takes the place of that. Double hip replacement, same principle for double knee replacement. It's 2 surgeries. There's a certain amount of blood loss you have to deal with. So I don't typically recommend it, but it's something you could do. After a hip or knee replacement, oftentimes people will use a walker for a couple weeks. And then hopefully they can transition to a cane somewhere between 2 and 4 weeks. Everyone's a little different. Are staples still used? And can you go to a rehab facility? Staples can be used. Most of our surgeons probably just use sutures that dissolve and glue. Makes for a little prettier incision, and then you don't have to get the staples out, so that's kind of nice. But it's on a case-by-case basis. There might be a reason I would use staples in a patient if they had a skin issue or something like that. Going to a rehab facility if you live alone. We highly recommend against going to rehab facilities. There is a lot of data in orthopedics, and a lot of it comes out of the Rothman Institute, that patients that go to the rehab facilities do worse after their surgery. And so we really recommend against it. If there's an absolute need, an absolute indication, I probably have 3 or 4% of patients that go to a rehab facility. But we usually recommend against it. A lot of the rehabs have sicker patients, have patients who have infections. So it's a great place to get an infection. Post-COVID, a lot of patients got COVID at rehab facilities. And then a lot of patients will get sent back to the hospital when they're in rehab facilities as well. So we really don't recommend it. And believe it or not, we actually publish literature that shows patients can actually go home alone after the surgery, because really their function is usually a little better after the surgery. And especially with a walker, they're a little more stable. So every situation's different, but on the whole, we really recommend against rehab facilities. Diagnosed with right knee arthritis, got short-term relief from injections, an active person. What options are there to slow down deterioration? So to slow down deterioration, it's really pretty minimal. It's going to be exercise and weight loss or weight control. You probably don't have a ton of control over the rate of deterioration, but those are really it. So I would encourage someone in your situation to just be as active as you can. If your normal exercise routine causes pain, I would tell you to modify. So again, if you're a runner and you run marathons, maybe switch to an exercise bike or a road bike, things like that. So ideally, again, staying active and weight control. How long can you go with just cortisone shots if you have bone on bone? Everyone's different. There's no real timetable. The person who decides to have the hip or knee replacement is the patient. The doctor just tells them that this is an option for them. Someone's 85 and they want a knee replacement. Yes, you can, but it all depends on, what are your comorbidities? What are your support systems? You get the question about a caregiver at home to help. If there's family or friends that can help, there's other, visiting nurse services, there are options. Those would be things you talk about with your surgical team. Someone's 83 with a tibial plateau fracture. That's a fracture of the top part of the tibia, the bottom part of the knee joint. They still have hardware in the knee. A lot of times you'll have to remove some hardware from the knee before you can do a knee replacement. And knee replacement can be very successful in that patient population who have hardware in the knee. But it would depend on kind of how much hardware there is, where it is, where the old incisions are. Those are all considerations we have. We answered before, how long do joint replacements last? You can definitely expect or hope to get 20 years out of a hip or knee replacement. That's pretty reasonable. And, they can hopefully last longer than that. A healthy young athlete in the 20s diagnosed with arthritis. Running is painful after only 5 minutes. Honestly, I would recommend, all the non-operative treatment options. injections, anti-inflammatories, therapy. And if those don't work, I'd recommend activity modification. So maybe you stop running, maybe you start swimming, maybe you start biking. But I would do that before considering a surgery. Please explain what's actually expected to happen in the knee joint as a result of the injections. So the injections, the anti-inflammatories, they're all there to try to reduce inflammation. And the theory is if the inflammation goes away, the pain will go away. And that's it. They're not going to regrow cartilage. They're not going to do anything like that. They're just going to decrease inflammation. A patient was told they can have 11 shots and then need surgery. I have never heard of a number like that, so I'm not sure how that was obtained. But really, there's no limitation on the number of shots, but it's a question of, we wouldn't want to do shots if they're actually not effective. Can PRP injections reduce advancement of arthritis or heal a damaged knee? No. PRP injections have been shown to do a good job with inflammation, but they have not been shown to stop or reverse arthritic changes. Can you have a knee replacement if you have chronic kidney disease? Yes, you can. That's a situation where, again, we'd want to use our medical colleagues to optimize you and make sure you're as safe as you can be for surgery. A 75-year-old, how can we predict that a patient can use an alternate therapy? You can't. Basically, it's all trial and error. So whether it's anti-inflammatories like Motrin, whether it's cortisone, whether it's viscosupplementation injections, whether it's PRP stem cells, it is all trial and error. And so the hard part with PRP, stem cells, things like that is they're not typically covered by insurance. So you're spending $1,000, $5,000, $10,000 for a shot, and you don't know if it'll work. So I always tell people, look, go to somebody and ask them if it doesn't work, do I get my money back? And then if you get your money back, then go for it. If you don't get your money back, then you have a decision to make. So it's always good to get a couple opinions, right? So if you go to the person who just does knee replacement, that's probably what they're going to recommend. If you go to the person who just does the PRP and the stem cells, that's probably what they're going to recommend. So it's good to get a couple of opinions and to hear, what multiple people might think to decide the best option for you if you're on the fence. Trouble walking, pain at night. Ooh, where did that one go? Let's scroll up. Should you do therapy? Cortisone doesn't work. Should you do therapy and hyaluronic acid before thinking surgery? Yes, absolutely you should. Almost you can think of the therapy as like your pre-surgical therapy. So it's getting you ready for surgery. So yes, you should use the non-operative treatment options. I see patients all the time that just say, doc, let's just get this done. I'll say, well, let's slow down. Let's use the non-operative treatment methods. Let's get you in the best shape possible for surgery. What hospital can you do knee replacement instead of having to go to a city, Philadelphia? We are, I don't know, Melanie, we're in like probably 20 or 30 hospitals in the New York to South Jersey to Western Philly area. So there's plenty of places we can send you to. We even have a couple of specialty hospitals and some surgery centers you could go to as well. Is the pain in the hip itself from the side to back pocket area due to issues with the hip or the lumbar spine? Ted Cohen, that's a great question, and that's hard to differentiate. So the best way to do that is with an exam. But yes, sometimes you can go to a doctor thinking you have a hip problem, but you actually have a lumbar spine or a low back problem, and the vice versa happens as well. So it's always good to go, get an exam, answer all the questions for the doctor, and get an x-ray to figure it out. Someone had a knee replacement at Pennsylvania Hospital 3 years ago, a partial, then a full, but the knee still hurts. Hold on.
I'm sorry.
That's okay. Been to Rothman, told the other knee needs to be replaced, and then you replace a little loose. Yeah, I mean, it sounds like you need to talk to your surgeon, but sometimes these things happen where you have a partial knee replacement. I didn't even get into that today. Sorry. And then it gets converted to a full, and maybe there's still some dissatisfaction. So it sounds like you probably need a workup, and maybe you have the other side that's bad too. So that might not be an ideal situation. If you have a hip replacement, when can you golf? Common question. Number one, with hip replacements, usually your swing will get a little longer because your hips rotate a little more. So you might be able to drive it a little further. I recommend people kind of wait to hit up the driving range till about the 4 to 6 week mark. And I recommend you don't really golf till about the 2 month mark. What you want in a hip replacement is you want your bone to grow into the implant. And if you're doing too much too soon, that could like not happen. And then the hip replacement might fail. So doing too much activity too soon is a bad thing. You kind of have to hit a balance there. So I think golfing somewhere between 4 and 8 weeks after surgery is reasonable. Can you have a knee replacement or a hip replacement if you're on blood thinners? Yes, you can. Those are managed by our medical team, and we work with them to make sure that's safe to come off of blood thinners. The option mentioned besides replacement surgery for knees, so anti-inflammatories like Motrin, Tylenol, Aleve, steroid injections, gel injections like visco supplementation, and then there's regenerative options like PRP and stem cells that aren't covered by insurance. And then the big one is weight loss. For every pound you weigh, it costs 7 pounds of force on your knee. And so even losing weight can actually be a great option to decrease knee pain. I do operate at Capitol Health Hopewell Hospital in New Jersey. Somebody just had a revision of their hip replacement, and now they need a knee on the opposite side, and the legs feel uneven. Usually knee replacements don't impact leg lengths, but hip replacements can. So that's something to talk to your surgeon about to address it. But the knee replacement shouldn't affect your leg lengths. Someone has rheumatoid arthritis, and yes, hip and knee replacements work for that as well. Someone's bone on bone with a torn meniscus, wondering why they can't have an arthroscopy. Well, it's not ideal that you have an arthroscopy because we know that people with arthritis that have knee scopes typically don't do well. So in an ideal world, we would just operate on you once. And so doing an arthroscopic surgery to clean up your meniscus tear is fine. The problem is if 6 weeks later you come back to the doctor and say, well, doc, my knee still hurts. The doc's going to say, well, yeah, you have bone-on-bone arthritis. Let's do a knee replacement. So not ideal to do 2 surgeries. We'd rather just do one. And so that's why a lot of times we don't recommend arthroscopic surgery for people with meniscus tears who have arthritis. Someone this is a success story. I love it. Had both knees replaced a couple years apart. Second recovery was a little better than the first. Year down the line, good mobility and no pain. That's what we like to hear. How many hip replacements do you do in a week? Typically, depends on the week, could be anywhere from like 4 to 10. We have surgeons who do more and less than that every week. Can you tell from a hip x-ray if the hip replacement is the best course of action? You can tell if a hip replacement is indicated, but I think you need to take the whole picture. So you need to understand the patient's complaints and limitations. You need to examine them. So that physical exam is really important. So that's why we love to do telehealth visits, but at some point we do have to get our hands on you. And then the x-ray is another tool that will help us decide, what's the best treatment. Possible complications for someone who's 85 and older. The list is endless. It's really no different from someone who's 65 or 45. But unfortunately, as we get older, the complication rates tend to increase, especially the medical ones like heart attacks and strokes and things like that. How long will the knee replacement last? We've kind of addressed. You can hope that it'll last about 20 years. The hope is they'll last longer. Met with the surgeon once. Should you see the surgeon again? That's up to you. That's up to your comfort level. Did you get all your questions answered? Do you feel comfortable with that surgeon? So you should take the time you need to make that surgical decision. How effective are fluid injections versus cortisone? They can be just as effective. They're just different. So again, it's all trial and error. And so you just got to try these non-operative treatments and see what works for you. Is a hip replacement viable for a patient having a Harrington rod for scoliosis? Yes, it is. Had a hip replacement in 2008, long time ago. Had a fall on March 1st and broke the femur. This past June, had some thigh pain, had a metal on metal hip. Doctor was going to do a bearing replacement and found the femoral stem was broken. Surgery was much more involved. Is this a common problem? No. But it is something that can happen. And we deal with these types of issues. And so it is something that can happen. So it's tough to recover from, but you can make a recovery. There's a long-acting steroid called Zilretta. That's a good medication. It's an alternative. It can work. It's not always covered by insurance. The studies haven't shown it to be that much better than the regular steroids, so it's not something I really use. We've answered how long do replacements last, 10 or probably about 20 years, 80 to 90% of the time. Where do you obtain a program for balance pre-surgery? Usually you'd go to a physical therapist before surgery. In preparation, are there specific exercises? Yes, there are. Again, a therapist could help you with that. A lot of our surgeons have their own exercise program they give patients. Can knee arthritis pain improve after hip replacement? The short answer to that is no. But can knee pain improve after hip replacement? Sometimes yes, because sometimes your knee pain is actually coming from your hip. Someone says their legs are bowed. The doctor straightened them. Yeah, that can happen. Very commonly, people can have bowed legs, and with knee replacement surgery, we oftentimes can straighten that out, and that can help. Does cortisone injections make the bone more brittle? Yeah, they're not without any negative effect. So cortisone injections, that's why we use them with some discretion. But once you have arthritis, it is a reasonably safe option. But they can have bad effect on cartilage or bone if you have too many of them. Love my hip replacements and will get it done again. That's a great success story. Is there anything you can't do after a knee, I'll say, or a hip replacement? And my answer is no. You can do whatever you want. I'm doing this surgery for patients because I want them to do the things they want to do. Now, we have to be realistic. You're not going to be able to do things that you weren't doing before surgery. So I tell patients, whatever you were doing in the 6 months before surgery is what you'll be able to do after the surgery, and hopefully you'll be doing it without pain. So for example, if you're someone that likes to snow ski and you last did that, 20 years ago, it's not likely you'll get back to that after your knee or hip replacement. But I wouldn't tell you couldn't try. So that's the caveat. It's really your preoperative function is going to dictate your postoperative function. Is there a new less invasive procedure where the doctor inserts circular pads for cushioning between bone on bone? No, that does not exist. How common is it to get blood clots? Not that common. We usually have everybody on some type of medication or protocol to prevent blood clots. How do I know if I need an MRI after steroid injections before surgery? You don't typically need an MRI to diagnose or treat knee or hip arthritis. Is cardio, strength, and balance in the pool with a trainer helpful? Certainly. Exercise in a pool is great. Take some load off your joints, so it can absolutely be helpful. What supports the new knee replacement if you take away all that stuff? Basically, the implants take the place of the ACL, the meniscus, etc. So your knee can still function. After X-ray and MRI, patient was diagnosed with a hip labral tear and arthritis. The tear, can you explain the tear? So it's kind of like the meniscus in the knee. If you have arthritis and you've lost space between the bones, the labrum can get macerated and torn. So what happens is people come in and say, oh, well, I have a labral tear, I want this fixed. But again, if you fix the labral tear or cut out part of the labrum and then they still have arthritis, the problem is still there, that's arthritis. So now again, you're not doing one surgery on them, you're doing two. And believe it or not, we get paid per surgery, but we would prefer to do one surgery and have the patient do really well, as opposed to having multiple surgeries. So that's why when you have arthritis in the knee and you have a meniscus tear and you have arthritis in the hip and you have a labral tear, your orthopedic surgeon's usually going to tell you not to worry about the labral or meniscus tear because those are the secondary or smaller problems. Is there such a thing as non-invasive treatment? Sure. Weight loss and anti-inflammatories, I consider them non-invasive. Some may not, but injections, some may consider invasive. You're putting something inside of you there. And then surgery certainly is invasive, but certainly you don't have to have surgery. And that's why, I wanted to present options to people today. What are the dangers of long-term anti-inflammatories? They are multiple. If you look at the bottles or a prescription anti-inflammatory, there's a lot of possible outcomes, which again is why it comes back to, for that conservative treatment, you want to try it and see how it affects you. If you're going to be on an anti-inflammatory for more than 6 weeks, it's probably reasonable to talk to your primary care doctor, get your kidney and liver function checked to make sure you're not having an adverse effect. And then also they can cause GI ulcers. So as long as you're tolerating it well in your GI tract, that's okay. I'm on Plavix. You can still get a hip replacement. You'll stop your Plavix 7 days before surgery. Find ibuprofen, it gives me some relief. Yeah, just like I said with anti-inflammatories, they can have adverse effects. If you're taking them, on a daily basis for a long period of time, 6 to 8 weeks, then you may want to consider talking to your primary care about it. What hospitals do I operate out of? I operate at Capitol Health Hopewell Hospital, where I'm the Joint Replacement Director. Also operate at Rothman Specialty Hospital in Robert Wood Hamilton and a surgery center in Hamilton as well. Can you explain full versus partial knee? There's an option where instead of replacing the entire knee surface, you just replace part of it. It's a good procedure for about the 10 to 20% of patients who are indicated for it. You just need an X-ray and an exam to figure out if you're indicated for it. Are some gel injections better than others? No, they're all the same. So you just take what your insurance company makes you not pay for. Are supplements helpful? They can be. Supplements are not going to regrow cartilage or anything like that, but they can have an anti-inflammatory effect. So again, it's trial and error. Try it. If it works for you, great. If it doesn't, move on. Herbal patches, again, sure, try it. If it works for you, great. If it doesn't, move on. Hip or knee replacement, which takes longer to recover. The knee is definitely harder. Is there an age at which point surgery is not recommended? I don't have a cutoff, but again, as we get past 85, 87, 91, there are higher rates of complications. So it's just important to be aware of those going into surgery. What's the best place to get exercise, I guess, before and after surgery? I mean, you can do exercise anywhere. You can do it in your house. You can go to a PT gym, whatever works for you, as long as you do the exercises. Swimming is a great exercise for someone with arthritic joints to kind of decrease the impact or pounding on your joints. When does nerve regeneration and sensation to touch typically return post-op? Everybody's a little different. Sometimes you can have some nerve damage after surgery, which causes some numbness, which usually isn't of a functional consequence. It can take, 6 weeks, 6 months, or never come back. So everybody's a little different. 47 years old with arthritis in both knees, you can have a knee replacement whenever you want. It's all about kind of the risk and the benefit and how much it affects you and how bad the arthritis is. What I would say is it's a quality of life surgery. So if your quality of life is really bad, just do it. If you feel like you can live with it and you're happy and you can do all the things you want to do, then you can wait. Have received the visco supplementation injections. Again, we've talked about the conservative treatment options, visco injections, cortisone injections, anti-inflammatories, weight loss, physical therapy. So yeah, I mean, those are the main ones. You could try PRP or stem cells. Exercise bike is a great option for people with knee arthritis. High blood pressure limits to Tylenol. That stinks because anti-inflammatories are better. But if you have high blood pressure or you're on blood thinners, you can't take anti-inflammatories. So you're at a little bit of a disadvantage, Diane. Cortisone shots, they can cause some damage to cartilage, but ultimately in people with arthritis, the cartilage is already damaged. So kind of doesn't really matter if they damage it. The hope is you get pain relief. Can you use a knee sleeve instead of surgery? Sure, you can try any number of braces out there to see if it alleviates pain and improves function. Can a patient take Celebrex? Yes, that's in the class of anti-inflammatories or NSAIDs. PRP for the hip did not work for me. Sorry, you probably need to see us for a hip replacement, or at least an x-ray at that point. Gel injections, yeah, again, you're going to just go with what your insurance dictates. I think we're getting a bunch of repeat questions here. Somebody had a hip replacement in 1996 and 26 years later needed a revision. Well, that's great. 26 years out of that one hip is great. So I'm glad that person did well. Usually you can swim after a hip or knee replacement once the incision's completely healed, which is about 4 weeks. Acupuncture can help in the knees. Again, it's another non-operative treatment. Try it, see if it works for you. It is realistic to be able to ski and do uphill hiking after a knee replacement if you're doing that currently. You haven't done that in 10 or 15 years, it is not that realistic. In a case of a not good candidate for a knee replacement, what's an alternative? There aren't great ones sometimes. At end-stage arthritis, you can try pain management procedures like nerve ablation or cryotherapy or bracing, but sometimes there aren't great options, and that's unfortunate. At what age can you start getting cortisone injections? Really, any age. I would advise you to wait. The older, the better. But once you have arthritis, the cat's sort of out of the bag, so it sort of is what it is. Someone had a hip replacement in August and has weak quads. That can be normal. I don't necessarily know your situation, but definitely something to talk to your doctor about. I had a partial knee replacement at Rothman at 86 years old, and Marilyn is pleased. We love that, Marilyn. Does osteoporosis affect arthritis? No, they are two. While they both affect bones, they are two different processes. But they can be related because many of our patients that we operate on do have osteoporosis or osteopenia, which is weaker bones. So they can be prone to fracture. Knees became bowed and found out that the hip is the issue for the surgeon visit. Yeah, I mean, the hip and knee are very related. It's all connected. So it's very possible. Can your body reject the implants? It's pretty rare. Some people may have an allergy to like nickel or cheap jewelry, and those people may reject standard implants. So there's a different type of implant out there. But for the most part, no, the body does not reject the implants. Meloxicam is an NSAID or an anti-inflammatory, a great medication for inflammation in the knees. 3 gel shots at Rothman last spring in the knee. Is it possible a different brand of gel might help? No, it's not. You could request it, but again, it comes back to what your insurance is going to cover and pay for. You're welcome for the information. Is it possible that what is a possible alternative than surgery for advanced arthritis? I think we've talked about that, right? So anti-inflammatories, weight loss, physical therapy, cortisone, gel injections, PRP, they're out there, acupuncture, bracing, all these things are out there, and it's just a trial and error. What's better for bone on bone, heat or ice? Try either, and whatever works, keep doing it. Bursa inflammation is something that's related to the joint. You can have a bursa sac around your joint, anywhere a muscle kind of rubs over or attaches to a bone. And that type of inflammation can typically be treated with anti-inflammatories, injections, and therapy. What brand of anti-inflammatory is the safest? They all kind of have a similar risk profile. Over-the-counter doesn't necessarily mean it's safer. What justifies a manipulation to the joint? Sometimes with knee replacement, if someone doesn't get their range of motion back, they can benefit from what's called a manipulation under anesthesia. It's a pretty specific situation. You're welcome. Voltaren's a great anti-inflammatory to use. It's also a great topical anti-inflammatory to use. You can rub it on your knees. If you get Voltaren gel, that's over the counter, can be really helpful. Haven't heard anything about a Baker's cyst. Baker's cyst isn't really part of knee arthritis. You can have those with a torn meniscus or with arthritis. The Baker's cysts tend to get better if you treat the problem. So if the problem's a torn meniscus, treat that, the Baker's cyst will go away. If it's knee arthritis, treat the knee arthritis, the Baker's cyst will go away. A recumbent bike is good for the hip or the knee. Anti-inflammatories and blood pressure, it's concerning. So that's something you'd want to talk to your medical doctor. But again, it's going to come back to trial and error. So your medical doctor might say, okay, take an anti-inflammatory for a week and let's check your blood pressure and see what it does. You're welcome. Got here late, 61, both are worn out. Can you get both done at the same time? No, I mean, you can. It's not ideal. It's going to be, you need to have the right patient and comorbidities. But it's tough to undergo both hips or both knee replacements at the same time. Someone's been diagnosed with osteonecrosis of the hip. That can be treated with hip replacement. There are some other non-arthroplasty options in very specific cases. So you need to consult with a surgeon specifically about that and get an MRI to see if you're a candidate. What type of sleeve don't you need to see orthopedic for bracing? No, you could just get an orthopedic sleeve at Target or Walmart and try it and see what happens. If you want something a little bulkier, we certainly can provide those braces for you and give you prescriptions. Thank you. You're welcome. I think we got through all those questions. You guys were great. A lot of really good questions. And yeah, I think we got to that first one too eventually. So really good questions. I hope everybody, the little one there, that was the one you saw. She's a lot bigger now. I guess I got to update that picture. But a lot of really good questions. I hope people found it interesting. We're here for you. We have, I don't know, Melanie, 35 offices around the area. A lot of great doctors and PAs that would love to help you guys manage your pain. Just because you have hip or knee pain, just because you have hip or knee arthritis doesn't mean you need a surgery. It may mean you eventually might want one, but it doesn't mean you need one now. So don't be afraid. Come get treatment, figure out your options, and we'd be happy to help. Thank you all for being here. This is probably the biggest one of these I've ever done. So this was a great crowd and a lot of really great questions.
Dr. Saxena, thank you so much. Thank you all for giving us your time tonight and this valuable information. I always learn something new every day. So the VIP line is right on the screen right now, 609-528-3670. If you guys want to make an appointment, I shared my email. You also have it in your email currently. If there's any questions we didn't answer, feel free to ask us and I'll pass it along to Dr. Saxena. So thank you so much for everything tonight.
Thanks, guys. Have a good night.
All right. Have a good one.
Thanks, Mel.
All right. You're welcome.